I genuinely think nurses and pharmacists need to know why these medicines are called Hedgehog inhibitors so that we can, in fact, effectively educate our patients. Just because to date, this class has the weirdest name I've encountered, and I almost expect at this point that my patients are going to ask me about it. I think that we need to be informed that just on where do these names come from, why is it called this, and does it matter to my patient?
And this podcast should hopefully provide some of that information so that we can speak at a high level on how these drugs function and kind of where that name came from. You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS, and today we're talking again with Andrew Ruplin, Clinical Oncology Pharmacist at Fred Hutchinson Cancer Center in Seattle, Washington, about Hedgehog pathway inhibitors. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in our episode notes. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation that we've linked in the episode notes. Welcome back. Thanks so much for joining us again today, Andrew.
Thanks. Glad to be back. And I've done this enough that I don't have to even remind you how to say my last name.
That's how you know it's been a good relationship. We just keep having you back. You do a great job.
Thank you.
To start today, can you give us a brief overview of the history of this very uniquely named Hedgehog pathway inhibitors in the field of oncology?
So I think a lot of folks would be surprised to hear that basal cell carcinoma, which this all makes sense in a moment, but basal cell carcinoma is the most common cancer, actually by a long shot. Something like at least 2 million Americans each year will be diagnosed with basal cell carcinoma. This is actually more than other cancers combined. And this isn't talked about a lot because basal cell and squamous cell skin cancers are often excluded from cancer registries. However, despite this high prevalence, the metastatic rate of basal cell carcinoma is actually exceedingly also low at less than 0.1% too. This means, however, that advanced basal cell carcinoma is a sort of underserved cancer type with very few approved systemic therapies right now. Hedgehog inhibitors make up only 2 of 3 FDA-approved systemic therapies for BCC, actually. The Hedgehog pathway is definitely one of the most curiously named in all of cancer biology. So studies in developmental biology and embryology in the 1970s first identified an intracellular signaling molecule that was eventually named Hedgehog for the appearance of fruit fly larvae that were mutants in this gene, and they looked like hedgehogs under a microscope. This Hedgehog gene and consequent ligand that it codes for is a major pathway for embryonal morphology development and cellular differentiation of stem cells, and a mouthful for me, apparently. Mammals possess 3 hedgehog homologs: desert hedgehog, Indian hedgehog, and I'm not kidding you, Jamie, sonic hedgehog. Yeah, not a joke at all.
That's, well, good, because that's what everyone thinks of. So at least they included it in there just so that we all don't feel silly when that's all we think of.
Totally. Our understanding of the specific role of hedgehog in cancer progression came out of research into the inherited nevoid basal cell carcinoma syndrome, which is also called Gorlin syndrome, which dramatically predisposes affected persons to development of basal cell carcinomas, as well as medulloblastoma too. So the first hedgehog inhibitor, vismodegib, was approved by the FDA in 2012, followed by sunitinib in 2015. However, as I was doing my own research, as someone who actually practices in melanoma and not leukemia, I will totally admit I was blindsided when I found out of left field that a hedgehog inhibitor for acute myeloid leukemia, glastigib, see, I can't even say that one either, was approved in 2018.
We have a lot of words that are hard to say in oncology. So the fact that they gave us hedgehog, it feels a little comfortable. Finally, there's one that nobody questions how to say it because we all have that connection, at least to Sega Genesis and the Sonic the Hedgehog. Very interesting. And I really, especially those statistics you started out with about basal cell and just how prevalent it is, but also, as you mentioned, the flip side is that, usually very treatable, but those that aren't in that category that do have that metastatic or recurrence of that, as you said, underserved, rare sort of in that context. And so good to know that there are these treatments for basal cell that isn't easily, treated and cured, but still maybe not enough treatments for that. But interesting to hear about that and learn more about that today. So I appreciate that history that you've provided. Let's talk a little bit more about the specific mechanism of action of these hedgehog inhibitors.
Yeah. So before we even started this podcast, I was warning you about some of these names. So You're going to have to bear with me for a little bit here.
I'll try to contain the giggles.
Yeah, it's going to sound like I'm trying to speak in weird nursery rhymes, but I promise you all of these names are real. So this is also one of the most complicated mechanisms that I had to come up with a way to just verbally describe without visuals, because everything I'm going to talk about basically boiled down to this inhibits this, which inhibits this, and inhibits this, and then this. So basal cells have two associated transmembrane proteins sitting there on their surface. They have one called patched or patched 1 receptor and one called smooth end. And these two talk to each other. Patched normally keeps smooth end calm and dormant, who when it's quiet, when that smooth end is quiet, it allows a protein called suppressor of fused, or SUFU, as it's abbreviated, to hold on to these transcription factors that would regulate cellular proliferation and apoptosis, among some other things too, in the nucleus. Sonic hedgehog binds to patched, which then allows smooth end to activate and let SUFU release hold on those transcription factors so they can go to the nucleus. So genetic alterations in BCC make patched defective and then act on smooth end inappropriately. Sometimes it's in the presence of errant hedgehog proteins that maybe the tumor has developed, and sometimes it's just, it can't turn itself off. Basically, there's a few different ways that they've identified. So hedgehog inhibitors are actually physically inhibiting smooth end and not the hedgehog ligands directly at all. So hedgehog inhibitors aren't inhibiting hedgehog at all. But when you shut down smooth end, despite the presence of like a defectively active patched or in the presence of natural hedgehog, SUFU is going to hold on to those transcription factors, which are then not going to be able to go into the nucleus. And that's going to help prevent abnormal growth and proliferation that we see in cancer.
Thank you for that. I mean, I was able to follow that description, even though, as you said, without the visual, sometimes that's challenging when we're talking about these sort of related pathways and one thing leads to the next. But you were right. Some very interesting name choices. Thank you for explaining that. That certainly helps give context to how these agents do work. You mentioned earlier some of the drug names, but let's revisit those here again, just briefly. Are there subclasses of this hedgehog inhibitor class, or is it all just kind of one small group? And maybe just highlight again some of those examples of the common agents that we would frequently see.
Earlier, when I was talking about the history, I pretty much talked about the only three that we have approved currently. So vismodegib and sunitinib are both for basal cell carcinoma. And then we have glasdegib for AML. Both of them, let's talk about the approvals though too. So both vismodegib and sunitinib, which I'm also switching. I don't know if it's gib or jib. I'll be totally honest with you either. Been doing this for years, but I still don't know. Vismodegib, I should be consistent though, and sunitinib are approved for locally advanced basal cell carcinoma, but vismodegib is also approved for metastatic basal cell carcinoma. So there's a slight kind of differentiation there. There are some hedgehog inhibitors in clinical trials like seritigib and talatigib, but none I'm aware of that are impending with new drug applications. Some talatigib data suggests that it possesses efficacy in disease with resistance to vismodegib, which is great to always have. When you have some of these classes that have multiple agents in them, that we can actually have sequencing in some of these cancers where there may not be a huge diversity in the offerings that they have for them. So we always like that when we have sequencing data and we can stretch that class further out in a disease, but that's still investigational at this point. This one is kind of interesting though. So not classically a hedgehog inhibitor, but the antifungal medicine itraconazole actually inhibits smooth end activity mechanistically and structurally different a little bit from current hedgehog inhibitors. So there are actually some trials out there, and those trials may demonstrate that itraconazole might have a clinical role in the treatment of hedgehog pathway-associated cancers. But again, totally investigational right now.
Great. So now let's move on a little bit to the toxicities. What are the common toxicities or adverse events that we would associate with this class of drugs? And are there any that are unique to specific agents, or are they all very similar?
Many patients, unfortunately, will have side effects with this class. I mean, and I know that's not controversial, but you actually find call outs in some of the kind of the national consensus guidelines. These treatments might not be tolerable for a decent number of patients. Some of these side effects can certainly reduce quality of life. Again, nothing that controversial here when we say it out loud, but just the frequency with which it occurs can make it quite difficult for some patients. So things like muscle spasms, more broadly, musculoskeletal pain, hair thinning, taste changes, fatigue, nausea, diarrhea. Those are kind of the big ones that seem to be largely universal across the three approved hedgehog inhibitors that I saw. In AML, just to kind of touch on that, again, the Glasdegib Hedgehog inhibitor is given concurrently with low-dose cytarabine, which is, of course, cytotoxic chemotherapy. So the overall side effect profile of the combined regimen may be somewhat, of course, different from patients who are doing just Hedgehog inhibitor monotherapy in basal cell carcinoma. If you look at the data on like Glasdegib side effect reporting, it's kind of more so in the setting of given in combination with chemotherapy. So slightly different interpretation overall. Glasdegib can more uniquely prolong the QT interval, again, based on what we've seen. Of note, and this is definitely a class side effect, but it's important to point out because we'll talk about it later. But because of the role of the Hedgehog pathway in embryonal development, these agents are highly embryotoxic, fetotoxic, and teratogenic overall.
Very important thing to point out. And as you mentioned, we'll touch on that here shortly. Well, and I think, as you mentioned, side effects can be intolerable for some patients. You layer that over your previous statement of like, well, there aren't also a lot of therapies for basal cell. And so there aren't a lot of therapies. And the ones that we do have are really challenging to tolerate. It does just kind of put all of that into context, into a different light of just, it's good to have these, certainly wanting to try to keep patients on them if they are showing efficacy, but acknowledging that there might not be a lot of other alternatives if they're not tolerable or if they're not working. So I think all of that is important context to keep. Can you talk a little bit about some of the strategies that we can use to either prevent or manage those toxicities?
Certainly based on what we said before, I think one of the easiest things to do for patients starting this class is to just make sure that they have really classical supportive medicines like antidiarrheals and antiemetics before they start treatment. Diarrhea and nausea occurred in about 20 to 40% of patients across trials. So certainly patients should be aware of that risk. Again, not a controversial side effect, but it's just simple things we can do to make sure that our patients are equipped to start treatment is to make sure that they have these medicines and they're educated on how to use them too. Musculoskeletal pain and muscle spasm don't seem to have really a standardized approach to management that I've ever seen. Some published experiences include magnesium supplementation, gabapentin, amlodipine. I saw all of that stuff. I've personally not really done that in my patients. The other one that I've also seen is, unsurprisingly, muscle relaxants. So cyclobenzaprine has shown relief in some, but not all patients, unfortunately. So going along with that, like, what do we do when you don't have pharmacologic methods or medicines that can treat side effects? For some of the muscle symptoms, non-pharmacologic methods like exercise, massage, and acupuncture could be considered too, and probably should be considered at some point. Holding Hedgehog inhibitor or dose reduction is, again, for better or for worse, the most consistently beneficial method to relieve muscle spasm. These muscle spasms or cramps might not appear for about 1 to 3 months in patients after they start, so just being aware of that. Taste changes and hair loss are definitely reversible after stopping treatment, but methods of treating these side effects during treatment with a Hedgehog inhibitor have really largely been unsuccessful.
Hair loss to me sounds somewhat unique across other targeted therapies that we've discussed in this series, as we don't often see as much hair loss or hair thinning with some of these targeted agents. Certainly makes sense why this one would have that. But I think that's something to keep in mind and make sure patients are aware that that's a risk for this, just because I think we often associate that with more classic chemotherapy. But that's something certainly to keep in mind to educate our patients about. What administration considerations should we as nurses keep in mind for our patients when we're helping to administer or educate our patients on these Hedgehog inhibitors?
I mean, I think they're pretty easy to administer. All three of them, the approved ones, are once-a-day medicines. Sinitigib should be given on an empty stomach, so that classical 1 hour before a meal, or at least 2 hours after. Sinitigib and Glasdegib are sensitive to drug interactions because of metabolism through the CYP3A pathway. And this also includes, I think, what I've talked about before on other podcasts with you. But of course, we need to keep in mind that food interaction with grapefruit. And I think on the other podcast, I talked about how it's not just grapefruit. It's some things like pomelos, tangelos, Seville oranges, and things like that too. So being aware that even though grapefruit is kind of the most common one we speak about, again, acknowledging that there's other citrus fruits that can have that interaction too. Drug interaction studies, conversely, haven't really shown as many changes to vismodegib when they studied it with several different kind of degrees and types of the CYP450 enzyme modulators. So probably a fewer drug interactions with vismodegib that need to be taken into consideration. But overall, maybe ask your pharmacist or run a drug interaction check if you're thinking of starting these agents or patients who are reporting new medicines.
Let's move on to some of the patient education points that we should emphasize. What are some of the, I think the highlights that we should communicate with our patients and their caregivers as the patient is about to start on a Hedgehog inhibitor?
So I think patients need to be aware that side effects as I had mentioned before, can be especially frequent with this class. So for a patient, they need to be aware that communicating your needs to your oncology team is really crucial to their own ability to use these treatments with minimal interruptions. Likewise, the oncology team should also set expectations that some patients will still need breaks in their treatment, and that's not abnormal with this class. One thing that I noticed, and I'm going to spend a little bit of length on right now, is just talking about how this class has by far the strictest recommendations for prevention of pregnancy and fetal harm and exposure of even other persons. So not the patient, but exposure of partners and other persons too, that I've really ever encountered. And each hedgehog inhibitor is different too. So pregnancy needs to be avoided in all instances. We know that. This recommendations, if you look at the package inserts prescribing info, actually even extend to males receiving the medicine who've had a vasectomy too. That's how serious the FDA seems to be about this warning. So to kind of summarize them, male patients on vismodegib should not expose female partners to semen during treatment and for even 3 months after the final dose. The prescribing info also makes it a point to recommend, oddly enough, donating semen in the same time frame as well. And patients shouldn't even donate blood for a whopping 24 months after the final dose. Although it's not that, in my experience, patients with advanced cancer are usually itching to donate blood either. Patients on sunitigib shouldn't expose their female partners with reproductive potential for 8 months after the last dose and shouldn't donate blood for 20 months. Patients on glasdegib should not expose their female partners to semen for 30 days after the last dose, nor should they donate blood in that same time frame either. So pretty extreme. Again, maybe we'll talk about this a little bit later, but kind of my thoughts on these recommendations and whatnot, but definitely something to keep in mind, for patients who are in that window of reproductive potential and things like that.
Absolutely. And as you mentioned, many other drugs they reference those recommendations, perhaps not as stringent or not as long, but in this case, it is not just something to kind of just look over and move on with, but actually there's lots of specific and extended recommendations that it's really important for us to communicate. And as you mentioned, like asking some of those questions like, do you regularly donate blood? Do you regularly donate sperm? Like those are things that we don't normally ask, I don't think. And as you mentioned, probably wouldn't be the top thing a patient would be considering doing even if they did previously, but important things to ask and emphasize, especially in this case. One question that just came to my mind, are these drugs like on a REMS program?
They're actually not, despite what we think about other kind of like highly fetal toxic and teratogenic medicines like immunomodulatory agents for like multiple myeloma. There's no REMS program for this. It's purely loyalty or trust, if you want to put it that way.
So how do you think pharmacists and oncology nurses can best collaborate to help our patients as they manage their adverse events or toxicities, and how we provide education and just serve as that trusted and reliable source of information for them as they go out throughout their therapy?
Kind of one little, if I'm allowed to kind of plug ourselves a little bit after one of our past podcasts that we did together. So since then, my center is really trying to standardize and expand our pharmacist-led programs for routine monitoring of different types of oral oncolytics. That way we can have multiple touch points with patients and then intervene with evidence-based approaches pretty consistently. Our nurses have been a really big part of that too, and their buy-in and support has been immensely helpful to make these programs successful for not just us, the pharmacists, but our patients and our clinics, and then the center as a whole too. I think that regardless of whoever's following up with our patients, though, as our arsenal of oral anti-cancer therapies does continue to expand, both nurses and pharmacists need to have specialized knowledge of these agents to be successful in their patient care roles. I've been reflecting on this a little bit more recently and just thinking about, are we getting to the point of like subspecialties in oncology for nurses and pharmacists even? I mean, my training and residency was to hit upon every type of cancer, but now we're kind of getting into this era of there are just so many new systemic therapies out there that many pharmacists in oncology, including myself, end up kind of subspecializing in certain diseases, either by design or by circumstance. I've even heard talk before and not that long ago that maybe pharmacy might end up making these specialties more official and formal within our profession. And I don't know if, nursing will ever do that either, but certainly at my center, my nurses feel very comfortable in their clinics and maybe not so comfortable in other clinics.
Absolutely. I agree with you wholeheartedly. Even just looking over the whole landscape of oncology, it is a lot of information. And as you mentioned, sort of out of just design and logistics, we do see subspecialization happening, especially in like large academic centers where there are these very distinct programs. And the physician colleagues, they are specialized. And so nurses kind of in turn follow that same pathway. But when you think of community practices that aren't affiliated with academic centers, those nurses, those pharmacists, those clinicians, those physicians, they all have to kind of know a little bit about everything. So it is, I agree, becoming increasingly complex to be able to kind of know it all. And so I really appreciate your comments about that. When we think about just the modality of therapy or sort of the route of administration, I think nursing, we especially have recognized that oral administration, oral adherence, and patients who are on perhaps strictly or single agent orals versus getting some component of IV, they need and deserve sort of different management and support because it's sort of on them. They assume a lot of that responsibility. And so we need to be able to support them and stay in touch with them in a different way that we can do because they're not coming for those getting it intravenous or other internal routes of administration that we have to help provide. We see them more often. So we have those touch points built in, and we know that oral therapies don't provide that in the exact same way. So 100% agree with all of your comments. And I think there's lots of work needed and support needed in oral therapies. And as you pointed out, there's room for everyone. I think pharmacists and nurses, we all can and should play a role, and depending on how your institution's ability to kind of set that program up, if it's distinct or just an integrated part of the routine practice, identifying who can play a part in that, who can contribute and support patients. Again, it's all for them. It's what they need to be able to feel comfortable and confident in taking their therapy. And so I really appreciate your comments on that.
Yeah, absolutely.
So what do you think the future looks like for these Hedgehog inhibitors and their role in other cancer care?
I'll be honest with you, I had to dig a little bit for this one. There's numerous trials investigating Hedgehog inhibitors in different diseases in different settings. So like early stage versus later stage and whatnot. Both as monotherapy or in combination with other anti-cancer therapies like immune checkpoint inhibitors or cytotoxic chemotherapy. So that's true for a lot of cancers these days. We're seeing as the classes diversify, or the meta classes, you will, of like targeted therapy, immunotherapy, cytotoxic chemotherapy, more and more, we're just investigating how these different modalities and combinations can treat cancer better. And that's no different for Hedgehog inhibitors either. One thing I alluded to before, but I still think is really cool when we talk about repurposing medicines, but itraconazole is being more rigorously studied, actually as not like an adjunct, but as a primary therapy for cancer at this point, based on those incidental kind of Hedgehog inhibitor properties. So we might actually see approvals maybe someday, who knows? I don't want to speculate too much, but itraconazole being both an approved antifungal agent and maybe an approved anti-cancer agent. We'll see.
Very interesting. Sort of never know what's going to come down the pike, but lots of new things seem to be coming all the time. So something to look out for. And I appreciate you providing some of that information for our listeners. Well, Andrew, we find ourselves again at the end of another great episode, a very interesting drug class that we've covered today. And as we do with all of our episodes, we like to close things out with just a brief kind of quick fire session of questions to help summarize some of the things that we've discussed. So to start that off, how do you think healthcare professionals can evaluate their hidden or their implicit bias when it comes to Hedgehog pathway inhibitors?
You and I kind of alluded to this earlier. As pharmacists and nurses, I think we're really used to counseling on reproductive risks with cancer therapies, but I think we kind of do it pretty generally. I find that sometimes that is for a reason, and more often than not, it's due to an understandable lack of human data on these therapies. And we have imprecise recommendations for reproductive health because of most of the times these reproductive issues are identified in animals. And once they identify that, it's never going to be tested in a human. I can tell patients things like they need to avoid exposing their partners to sexual body fluids, but I can't always be as specific as I like as to why exactly or for how long. I mean, I have patients who, when I say, you should use barrier contraception and not expose your partner to these bodily fluids, and they're like, well, am I going to harm them if they get exposed to like saliva or semen or all that? And I have to apologize and be like, you know what? We don't really know in a lot of cases. So it frustrates me at least a little bit to speak from these positions of ignorance, even though it's no one's fault, but it's frustrating nonetheless. Although again, I find that just honesty with patients tends to be something that they appreciate. And I'm really open with patients about the lack of data to guide these recommendations, but they also appreciate that I really value their safety and I take it very seriously for both them and their partners and other loved ones. And people are really perceptive to this honesty, I think, and about the limits of our knowledge. But when there are clear recommendations for reproductive health, as I summarized before with these agents, I obviously think we need to be aware of them and not just defer to these generic recommendations. Because if you just defer to, well, use barrier contraception and then for a week after your last dose, you're okay. That's not true with these agents.
And I'd say, especially for those side effects, we should not be assuming we know if a patient is sexually active or, what their lifestyle is. And so these recommendations need to be shared regardless of maybe our preconceived notion or our bias of what we think our patient, what's important to them or what really is relevant to them. We need to be consistent in emphasizing the importance of this. What do you think are some common misconceptions about hedgehog inhibitors?
I don't think there's really too many misconceptions I could think of. I guess I did want to, in fact, plug that even though this sounds really goofy, need to know why these medicines are called hedgehog inhibitors so that we can, in fact, effectively educate our patients. Just because to date, this class has the weirdest name I've encountered. And I almost expect at this point that my patients are going to ask me about it. And if I'm just sitting there and they're like, why, how does it work? Or what's a hedgehog inhibitor? And you're like, I don't know. That doesn't instill confidence, I think, in a patient, and justifiably so. I think it's not a misconception per se, but I think that we need to be informed that just on where do these names come from? Why is it called this? And does it matter to my patient?
And this podcast should hopefully provide some of that information so that we can speak at a high level on how these drugs function and kind of where that name came from. What's something about this topic that's not often discussed, but you wish people knew more about?
Probably partially because metastatic disease for BCC is so rare. It's that there's only 3 approved treatments right now. So we have the 2 hedgehog inhibitors, sunitinib and vismodegib, and then we have the PD-1 immune checkpoint inhibitor, cemiplimab, too. So really, it's just those 3. If you go look at national consensus guidelines, again, it's going to be pretty sparse in the systemic therapy options. It just speaks to the need for novel systemic therapies for this disease. It's also worth pointing out that for some patients, I think advanced basal cell carcinoma is extremely morbid. So if you go look on images online, if you've never encountered this disease in its advanced state before, but these can be extremely morbid and depending on where the location of the cancer is, it can be very distressing to a person's self-esteem. And I think more people who are not educated about this disease should just go, in fact, look at what the lived experience for a patient who has advanced BCC.
What additional training or education do oncology nurses need to stay current in this topic?
So hedgehog inhibitors have been approved for over 10 years now in BCC. And so the main trials like BOLT trial and ARADVANCE trial established sunitinib and vismodegib's role in advanced BCC. But since then, there hasn't been a lot of evidence to expand their use in this disease. So for now, I think nurses just really should be familiar with data that was published 10 years ago, which I have to chuckle at least a little bit because in oncology, 10 years is obscene. But in other specialties, we're looking maybe using studies from 20, 30 years ago that are informing contemporary practice. And yes, we do that in oncology. When we think of the landscape, 10 years is obscene in cancer nowadays. But I think we shouldn't discount these studies just because they are 10 years old now, because these are the ones that are still informing our practice to this day. And I think we need to be aware of that.
And finally, what are some additional resources that you might recommend for patients or other healthcare providers who want to learn more?
So despite a lack of abundance of new prospective data for hedgehog inhibitors, there have been multiple and clinical trial follow-up publications. So like longer term data, does follow-up at 5 years, follow-up at X years, things like that. Retrospective analyses and reviews based on experience and expertise. And these are all available, of course, online, either freely or through PubMed, through your institution, if you can access those. And that's where I draw a lot of my knowledge from, because again, I just don't have that many patients on these therapies that I see frequently. So I myself often have to refresh myself on, what are people doing at other centers and from expertise? What are they doing to help manage these patients and make them successful?
Well, Andrew, thank you again for another very interesting podcast about a very interesting and unique drug class. I appreciate your time and sharing all of your knowledge with us today. Do you have any final comments for our listeners?
So I appreciate being on yet again. And if anything, I hope at least one person laughed from listening to this podcast and hearing me say sonic hedgehog inhibitor in my actual professional practice.
If we didn't say it, I think they would be disappointed. So we had to say it at least once. Thank you so much, Andrew. It's been great talking with you today.
Thank you, as always.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.